Thank you for joining us today. I'm Jim Carroll, and I have the privilege of being the CEO of diaTribe. I'm grateful for our moderators and our panelists, and I'm really looking forward to the conversation today. It's all made possible by the generosity of our sponsors. A big thank you to Sanofi at the platinum level and Xeris at the gold. Abbott, Lilly, Sequel MedTech, and Vertex are all at the silver level, and Dexcom at bronze. It's their support that helps us share this kind of information that we all need to live healthier lives. When I think about the people who are shaping the future of diabetes care, two names immediately come to mind: Dr. Diana Isaacs and Dr. Natalie Bellini. Both have spent their careers making life better for people with diabetes, helping clinicians deliver better care, pushing for clearer standards, and making sure that we all have a more hopeful future. Their leadership extends far beyond their titles and their degrees, and it reflects a lifetime of hard work, dedication, and excellence. They're not just experts, they are the experts for the experts. They've served on national committees, they've influenced the ADA standards of care, and they brought diabetes technology from the cutting edge into everyday practice. But what stands out for me even more is their generosity to their patients, to their colleagues, to diaTribe, and to me personally. They've helped me navigate my own CGM and understand my diabetes medications. They've taught other members of the diaTribe team, and they've inspired us to make diabetes make sense for countless people around the world. Diana and Natalie have dedicated their lives to improving lives, caring for themselves, their families, their patients, and all people with diabetes. Their impact is measured not only in just how many publications or programs they've done, but in the trust that they've built and the hope that they've inspired across the diabetes community. So it is my honor to hand over today's program to two extraordinary leaders, Dr. Diana Isaacs and Dr. Natalie Bellini.
Wow. Well, thank you so much for that very kind introduction, Jim. And I want to thank diaTribe for the invitation to moderate this really exciting panel today. I'm going to get us started with a few opening remarks. So we are truly at a very unique time in type 1 screening history. We know this is becoming so important and actually hot off the press. Just last week, there was a new article published in Diabetic Care on this very 135,000 children, as well as 99,000 adult relatives of individuals with type 1 diabetes that were screened in the trial, compared progression rates, associations with risk factors, and performance of metabolic risk scores. And in brief summary, auto-antibody positive adult relatives have distinct auto-antibody, suggesting the need for truly tailored monitoring and intervention strategies. And so that is what we are here to talk about today. And as you'll see in this discussion, type 1 diabetes is definitely not just children, very commonly diagnosed in adults as well. And with that, I'm going to turn it over to Natalie to introduce our amazing rock star panel.
Thank you, Diana, and thank you everyone for joining today. So just in the interest and spirit of time, we're not going to give everyone the accolades that they deserve, but the diaTribe team has already posted the link with their bios that can be fully read online. So let's start with Dr. Corey Hood. Dr. Hood is a PhD personally and professionally committed to improving the lives of people with type 1 diabetes. As professor and staff psychologist at Stanford University School of Medicine, Dr. Hood runs a behavioral science laboratory aimed at optimizing health and quality of life outcomes. He is also a recipient of federal and foundational grants and author of over 200 scientific articles. Dr. Mia Kuiston, a native of Ann Arbor, Michigan, earned her BS in chemistry from Spelman College and her MD from Wayne State University School of Medicine. She completed her pediatric residency at the University of Michigan and is also an internationally board-certified lactation consultant. She's fluent in both English and Spanish. She has held diverse clinical and leadership roles, including work in diversity, equity, and inclusion. Dr. Eden Miller is an osteopathic board-certified family practitioner. She received her medical degree from Kirksville College of Osteopathic Medicine in 1997. She completed her residency in family practice at Eastmoreland Hospital in Portland, Oregon. She is board certified in family medicine and is a diplomat of the American College of Obesity Medicine and a newer group called the American College of Diabetology. She's co-founder of Diabetes Nation, a nonprofit organization, and CEO of Diabetes and Obesity Care LLC, where she actually practices with her husband, Dr. Kevin Miller, in Bend, Oregon. Dr. Miller has cultivated a special interest in diabetes after being diagnosed with type 1 diabetes while in medical school. Stacy Sims is the host of the award-winning podcast Diabetes Connections and the author of the world's worst diabetes mom book series. She hosts a program called Mom's Night Out and an in-person event for moms of children with diabetes. Stacy's son was diagnosed with type 1 in 2006, and her husband lives with type 2 diabetes. We will now start asking our panelists questions. And to all of you listening, drop questions in the chat box throughout, and our team will take as many as we can as time allows at the end. Lastly, please note that this is actually a 3-part series. So our next session is scheduled on September 11th. We will discuss why and when we rescreen and how we monitor those that are actually screened positive. Our final session will be on October 16th, where we will discuss current and future treatment options for those that screen positive. So let's start with one of my favorite people on the planet, because we both have type 1 diabetes, Dr. Eden Miller. Can you share with us some statistics and rates about the diagnosis of type 1 diabetes, both in children and adults?
Yeah, what's a little bit scary is we're trying to see this trending up. For a while it stayed pretty steady, but they're estimating in the next 15 or 20 years an additional 43% increase in the diagnosis of new type 1 diabetes. So as you can see, there's going to be a lot of newcomers, and what we really need to be mindful of is maybe identifying these people and preventing or slowing down that progression.
So how has this changed over the years since you were diagnosed, maybe, or even further back? And as a follow-up, are there certain people that are at higher risk?
Absolutely. I think for me, diabetes has been living with me for 30 years. And, when I did contract it, what I was glad for is that I didn't get misdiagnosed because my age. I think a lot of the top of line has been, your gender, what you look like, your age, your ethnicity. You don't get disqualified from screening or getting type 1. So for me, I think there's been a lot of awareness recently around identifying all persons, because we can come in all different shapes and sizes. I think there still is this big disconnect because there's a large amount of those that have type 1 diabetes who get misdiagnosed. And so I always say, if in doubt, check it out. It's not a big test. It's not hard to do. If you don't test, you're going to be 100% in the dark. If you do test a negative, great. But if you do test positive, we have opportunities for monitoring and really slowing down and lessening that big bombshell that can happen in people's lives.
Thank you very much. Stacy, so can you bring this a little bit more to life? Can you briefly share a story of your son's diagnosis and personally frame that with where does this go? How did that happen? And give us a little bit of an understanding of, you didn't know this was coming, and what did that look like to you?
Yeah, it was terrifying. I think, like most people who don't think they have type 1 diabetes in their family, it seems to come out of the blue. So my son was 23 months old. For a few weeks, we'd noticed some real weird stuff going on. Looking back, of course, it was the classic signs of type 1 diabetes. He was still in a diaper. He was still in a crib. So, he was just drinking and peeing, not sleeping, and then losing weight. And that's really what we noticed. So I took him to my pediatrician. And at the time, she said, bring him in. I've never seen it in anybody under 2 years old. So we're just going to rule it out. But luckily, she did the testing, ruled it in. And it was terrifying. Luckily, he was not in DKA. We were very fortunate that I had people around me. A friend of mine down the street is a pediatrician. I actually knew people at the local then JDRF chapter. So we had support and kind of a heads up of this might be it. But it was seemingly out of the blue, come to find out 3 years later, one of my first cousin's children was diagnosed with type 1 diabetes. So didn't really come out of the blue, but we didn't know that. And this was back in 2006, where screening was not as much a part of the conversation.
Wow. Thank you so much for sharing that. I actually want to turn it over to you, Maia. I'm curious, as a pediatrician, what do you see when one of your patients is newly diagnosed?
That's actually a really good question, Diana. And one of the reasons that I'm involved in this work is because I have a patient who at 10 started getting kind of thirsty just a little bit, but was running track. We didn't think anything of it. And so she took the trip to Bolivia for the first time to visit her grandmother. And while she was there, she started getting sick and she went into DKA. And unfortunately, Haley never made it home from Bolivia.
Oh.
And so it is, this is why I'm doing this work. And that is a story that is heartbreaking. And that was my first patient being diagnosed with type 1 diabetes. And so it's heartbreaking and we'll never let it happen again. Now, I have another patient. He was 5 or 6, and this wasn't on screening, but he was getting a little thirsty. So we brought him in, we did it, and I was so excited to do this test. Like, okay, we can really use this test because, as Stacy said, there's no way to screen. Eden said there's no way to screen in the past. So this is the first time I could do it. He's 6 years old. He's a little thirsty. Of course, his parents actually took a couple months to do the test. He came back positive for all 4 auto-antibodies. And you guys are going to talk about what we can do later on, but he's 6 and he's stuck. And there is all sorts of things. So he has 3 siblings. What do you do with his siblings? He has parents, and they don't really know what to do. They want to stay with me so I can follow them, but they want to see an endocrinologist. And so there's this myriad of feelings and emotions about what to do next. And it's really personal for everyone.
Wow. Thanks for sharing that story. I mean, I think we forget, like, DKA kills people. Like, people die from
Yeah.
it.
It is.
Can you talk a little bit about how common DK is and then other complications that might occur with a new diagnosis?
Yeah, so let me take a step back. And so with screening, you can reduce the risk of new onset DKA from like 60% to less than 5%. So I'm sorry, about 6%. It's actually really significant. And so the death rate from DKA in the United States is about 0.13, but 0.13 is a teeny number until it's the person in your family. And then if you're overseas, DK rates with death are as high as 13%. I keep focusing on death because we need to understand how serious this illness is. We need to understand that we're talking about something that is preventable, meaning dying with the stage 3 new onset type 1 diabetes is a preventable death when we screen and know how to manage, get anticipatory guidance, and prepare families what they need to do.
Oh, so I'm curious, how do you talk about screening to these families? Like, what words do you use with a?
Yeah. So to be transparent, I am team screen. So we all know that there's increased risk for screening if there is a family history. So as Stacy said, if there's a family history of type 1 diabetes, celiac disease, Graves' disease, Hashimoto's disease, HLA antibodies. So the way that I talk about it is, okay, who in your family has XYZ? If anyone in their family has a thyroid disease, I'm putting history of thyroid disease and I'm testing and I'm explaining why. So we can get anticipatory guidance. If anyone in their family has celiac disease, I'm putting family history of celiac disease and I'm screening and I'm telling why. And then I end with, like, how about any other autoimmune disease? Lupus, Sjogren's, ulcerative colitis, Crohn's, anything. And then insurances will cover it if you put family history and you screen. I explain if they haven't had any family history, why we're doing. What's really interesting is, since I've been doing this and asking these questions, I've had people say, well, my grandfather was just diagnosed at 61 after going a full year with nothing. He was misdiagnosed. I've had girlfriends who have told me, as an adult, they've been misdiagnosed because they're black and they're not the right race, and so they thought it was type 2 diabetes. I mean, all of these things that we're talking about, I tell these stories that I find, and I tell them why we're doing this to avoid this. And of course, we want to prevent DK, but I want to prevent another Haley. I don't want anyone to die. And I tell my story.
Yeah, I mean that sounds really powerful. I think if you were talking to me, I would be convinced I'd want to screen. Stacy, I am curious, your perspective. What do you see as the value of screening for type 1 diabetes?
Well, I mean, I think that as we just heard, preventing a DKA death would be the number one for sure. But it's interesting because just in my family, right, I have my cousin who was diagnosed a couple of years later at the age of 7. And they had a little bit of a rougher time than my son did, only because he was diagnosed a little bit later. But I think one of the issues is like, it's kind of scary. I almost we feel like in the community, sometimes I hear people like, well, I don't want to look for trouble. Like, we'll know it when we see it, right? We'll know the signs. And I think that one of the pieces of education I'd love to see more of, and again, I'm a layperson, right? I'm not a doctor. I don't see people and patients, and I don't have to educate in the same way. But it would be great to get the messages out like we're doing right now about, first, obviously, what can happen if a diagnosis is missed. But, not just for that immediate peace of mind, but like long term. And I know we're not talking about treatment and things like that today, but I think that's one of the reasons why I'll be totally transparent. I have a daughter. She's 3 years older than my son. We've never screened her. She's now 23, so it's her decision, and we're talking about it. But I didn't screen her when she was little. There were different ways to do it. Every year at diabetes camp, I'd drop my son off and there'd be, TrialNet, or there'd be different organizations as she got older. And we just never did it because I thought, well, we know what we're doing now. And I didn't want her to get an extra blood draw. And now like there's a lot of like weird feelings. I know that's not the technical term, but I think there are some weird feelings around screening. Am I looking for trouble? And I'm kind of ashamed I didn't do it now. So, gosh, I know it's hard to articulate, but I think those feelings are out there and they have to be part of the conversation.
I bet if Maya was your doctor, then maybe you would have screened.
Yeah, nobody's ever talked to us. I mean, I've talked to doctors about screening, but nobody's ever talked to us about it in the 18 years that my son has lived with type 1.
Wow, I'm glad we're having this conversation here today and people are hearing it so they can talk to their healthcare providers about it. Eden, I'm curious your perspective. What words that you use in your practice to bring up screening, if you have any examples to share.
I think what I first do is kind of what we call the low-hanging fruit. It's those individuals, because we do a womb-to-tomb diabetes, which I'm blessed. I see both pediatrics, adults as well. And so we do have a lot of conversations. I love Maya in talking about, you got an autoimmune disease, we're going to look for a second one. We do a lot of events every 6 months. We'll do a screening at our office. We will broadcast it through the area, do the pediatricians. We'll go through the school system. I'm quite tight with the school nurses as well. And so, yeah, you want to cast a wide net because you want to get those people, but you also want to get those that it's top of mind. And back to what Stacy said, I don't think a single person with diabetes, I think they all would have wished they could have known a little earlier. And that heads up does give them that chance for having the ability to cope with it, both mind, body, and spirit. And I think also as we learn with screening, because the more we screen, the more we see, the more we're going to see patterns, right? And I think we can also learn from that going forward. And so create in your own mind as a person, in your family history, and us as clinicians, we go out and educate. And I say, create your people that you want to screen. And again, I think also when you're dealing and dialoguing with clinicians, they sometimes kind of push back. Oh, you don't need to do that. Just say, it's okay. If it's negative, great. If it's positive, wow, I'm glad we knew. And I think it really, you meet the person where they're at and you talk about empowerment, because monitoring and screening gives you knowledge and that gives you that ability to intervene. We don't want to react, we want to be proactive.
Yeah, thanks for that. And then, we've kind of been alluding to there's a lot of feelings around this idea of screening. And then certainly if you get screened and you are positive, kind of, wow, what do you do next? And so, Corey, I'm curious to hear from you about the education that's needed to happen when someone's diagnosed, how quickly that needs to occur, and kind of the whole family dynamics, feelings around this transition.
Yeah, sure. I think, and this has been a great conversation so far, and um, a couple things already resonated with me that I think are relevant here. I think that most people, so leave it to the psychologist to say that like we need to disregard the feelings for a second, but to hold the feelings in one place. But most people want to be able to take some kind of action. And so when I talk about screening and the value of it, I often also say that now you can do something. And it's a little bit of a different story than the story we had 5 years ago because of new disease modifying therapies, which we're going to talk about in upcoming sessions. But really, I talk to a lot of people about part of the education is what actions can you do? And so a couple of pieces around education that I think are important. One is we spend a lot of time helping people be safe and be stable. If there are, the kind of typical diagnosis of type 1 diabetes is that way. Whenever there's antibody screening and they're positive, it's still this idea you have to help them understand that they're going to be safe and that we're going to be a team, we're going to be part of this together. People get really worried about it, even if we know as the kind of professional that it doesn't automatically mean that something bad is going to happen right away, but people get worried about it. And so I think that one of the first biggest parts of education is understanding that we're going to be with you, we're going to help you stay safe. This is kind of moving you in the direction of being able to take actions, know next steps. And one of the things that I think is really important is, no matter if we're HCPs or we're, family healthcare professionals, or if we're family members, caregivers, is that it's okay to acknowledge that this is stressful. When you do screening, if you get a positive result, it's stressful. And so I think that we really can do a lot just by validating people's feelings, and then helping them kind of move to some sort of action.
Thanks. Great. Those are great points.
So, Corey, I have one more question for you. So, we know you were diagnosed, and we have a running joke for all of you out there that Corey caught diabetes while he was getting his PhD in the lab.
Yeah.
Can you tell us a little bit about your diagnosis?
Yeah, sure. Yeah, so it's an interesting story. So it's 25 years ago, but I think that the so a little bit of the details. So I was working on my PhD, kind of conveniently working in type 1 diabetes because it was really one of the only chronic disease areas that was available and kind of taking in students. And so, I was maybe 6 months into working on it, and then realizing, wow, these are a lot of these same kind of symptoms that I'm reading about and understanding and learning about, and all the things that Stacy had mentioned before. Kind of typical presentation, going to the bathroom a lot, drinking a lot. I lost 25 pounds in the course of a few months. Um, so, but what was also tricky at the time was trying to convince the providers that like this would make sense, that a, early 20s would be diagnosed with type 1. And so it took a lot of advocacy for myself and kind of moving through that. But that's definitely why we kind of joke about it as catching it. I caught it from the people that I was working with. We know that that's not true, but that's definitely kind of sometimes is a little bit endearing to families. But since then, and I think that we're going to talk some more about screening, but my PhD was, on newborn genetic screening for type 1 diabetes. So this has been an area that really has been I've been deeply embedded in for 25 years.
So now you have children. And so can you tell us a little bit about making that choice to screen your children?
Yeah, sure. And this is, and I'm sharing here, and Natalie and I have talked about this quite a bit. And I don't think everybody, all of the people doing this work don't have to be as comfortable talking about this, but I'm really fine with talking about this. I it was kind of easy, say 25 years ago. So I have kind of two waves of kids. Some that are older in their 20s, and then younger in their, like, elementary days. And so it was different thoughts that were going on. I was interested in knowing about kind of the genetic profile, and we've heard about a number of autoimmune conditions that kind of sit together, and I have the thyroid and celiac and type 1. And so there's always been kind of a reason to worry about it in my kids. And so I always thought it made sense to do it. And then more recently, with the younger ones, it also felt like there were going to be more opportunities, and screening would potentially allow for an opportunity to delay the onset, but also to give them more time, because we know there are a number of advances and new treatments, new therapies that are coming on. So giving them another few months, giving them, any to years, giving them some more amount of time really allows the field to keep working. So my perspective has been that it's really good to know it. And we've heard kind of Team Screen and others talk about this. I'm very much on that side and think there's a lot of benefit to doing it.
Yeah, I think that is in and of itself, it's a hard thing. I think that we really do. When someone screens we order mammograms like this, we order colonoscopies like this, right? And then we get to screening for type 1, and people say, "Well, I don't know if I really want to know." And it's like I have that belief, and I think Eden and I, like, it's there, it's hiding, right? And so that is that idea that, like, it's there, just like you're BRCA positive or BRCA negative, just like you are, positive for other things. And to overcome that is a hard one, though, isn't it? And can you talk a little bit about the people that you have worked with that have stage 1 or stage 2, they've screened positive, and what that trajectory looks like versus meeting someone in an ICU, or you've gotten screened and here you are? Does anyone want to Corey, do you want to take that one on?
I can jump in first, and I definitely want to hear other perspectives on it. I think that, it's for people who have a family history, it's an easy kind of reference point. You don't want another kid to end up in DKA. You don't want another kid to have type 1. And so it's kind of an easy reference point and so psychologically, maybe it's a little bit easier to think about it. For people that don't have any awareness of it, you're not sure how bad it actually could be. And so I think that sometimes, while we don't want to, scare people, we do want them to understand that it's a pretty serious thing, and that there are ways to deal with it. So most of the time when people kind of resist screening, it's because it's a lot of psychological burden that's potentially there. And so one of the first things that we have to do is we have to approach that. We have to give them some psychoeducation about it, understand what's coming up, acknowledge that it could be stressful, but that we're here. And from a number of studies that have been done over the years, we know that when people are part of these programs, they get screened, they get followed as antibody positive, they feel their stress goes down over time. They feel like they're supported, and they have a better understanding of what their risk is.
Yeah.
Stacey, do you want to comment about that? Yeah, I'd love to hear.
I would love to jump in. Thank
To
you.
these moms, right?
Yeah.
Yeah.
Well, it's been really interesting because I started Mom's Night Out in January of 2023. And this is, as you said, an in-person event. We get about 65 to 75 moms in one place in different cities. And in 2024, we started hearing from moms whose children had been screened, tested positive, but didn't have, and pardon my ignorance on the language, but didn't have full-blown type 1 diabetes yet. But of course, we're welcome to come. And it was incredible because I always said I was the luckiest person. We're the luckiest family to have a kid diagnosed because I already knew people in the type 1 community. It's like I could call a friend from the hospital and say, hey, remember, you told me about your child and he's okay. My kid's going to be okay, right? And they were like, oh my gosh, we're going to be there in 5 minutes. And they welcomed us into the community in a very positive way. So these parents are getting support before they're having to administer insulin. And I think that makes such a big difference. I do worry because a couple of them have said, we feel like we're on an island. Like we don't know what we're doing yet. We don't, they have support from their medical team, but they're not sure how, it's funny, they're not sure how to act. There's no playbook for this. It's so new, but they're able to kind of come out and be with us and be with the community in a way that would have been impossible a couple of years ago. So I think that's really exciting. I do think, to Corey's point, the mental health aspect isn't there unless you're super lucky to have incredible healthcare providers like are on this call. But, we were never offered any kind of mental health help. And I worry about these families who are like waiting for the shoe to drop. You know it's coming and you're getting a lot of help and support. But I'm glad to hear that that's part of the picture and it's known that it's needed because, boy, my son's 20. I still feel like I need that kind of support.
Well, I think one of the things is when someone tests positive, they're in early stage type 1 diabetes. They have a diagnosis and that allows them then to be referred to diabetes education. And so we have a lot of diabetes care and education specialists. And I think it's important we refer to them and offer support for these people. Now, I want to switch gears a little bit and go back to you, actually, Maia, because we've been talking about screening. Like, what are we screening for? Can you tell us what these auto-antibodies are that we're actually checking for?
Yeah, that's a good. And I do want to stop and say, I know we're going back, but Corey, I love the term psychological burden. And just to answer the previous question real quick is the 6-year-old, you guys are going to talk about treatment later, but you guys know what it means to be 6 and not be at an age where you can actually do anything to delay. So I just want to, that's a huge psychological burden. But so when we talk about the auto-antibodies, there are 5 that you can test for. I typically, in my practice, I'm fortunate enough, I have a practice in Washington, D.C. We screen for lead and hemoglobin at 9 months and 2 years. And so the guidelines for screening for type 1 diabetes are auto-antibodies that have nothing to do with your blood sugar level. They're auto-antibodies that show that your body is reacting against itself. Specifically the islet cells that are attacking the pancreas. So there are 4 auto-antibodies that I screen for. If you screen and you have 2 or more positive auto-antibodies, it's almost certain that at some point in your life, you will reach stage 3 type 1 diabetes. Stage 3 type 1 diabetes is the point where you actually need insulin. One thing we haven't really talked about is if a patient tests positive for 1. And that is, again, I love the new term, that is a huge psychological burden because these are people that are in between. And so if someone has 1 and they're less than 3, you screen every 3 months. You screen every 6 months until they're 3, and then you screen every year for 3 more years. If they're older, you screen. But if you have 1 autoantibody, you may at some point have another autoantibody, which equals 2, which is the 2 autoantibodies that mean at some point in life you will need insulin. And so as we're counseling, we give anticipatory guidance, what we're looking for. It is actually really scary to have 1 autoantibody because you're waiting for the other shoe to drop. And so you have 1 autoantibody and then you confirm that autoantibody and you start adding to monitor glucose. And so you're monitoring people's glucose levels along with autoantibodies. Prayerfully, nobody converts and has 2 autoantibodies or even 3 or 4. But what you're looking for is if someone has the autoantibodies, and then if someone does have those autoantibodies, then you start to monitor their blood sugar levels to see at which point in time, again, you guys are going to talk about later, they could either have some sort of intervention to delay the onset of stage 3 type 1 diabetes, or when it's time to actually start insulin. And what I do is I actually would refer them early. A lot of times, as a primary care physician, they want to follow you, but you also want them to be plugged in if for some reason they do need to see a specialist sooner rather than later.
Yeah, thanks. Those are great points. And yeah, it's true. You can test positive for one autoantibody. And this new paper that was published last week talks about this. A lot of people may not go on to progress to two autoantibodies.
Right.
So it's not necessarily like cause for alarm. It's just, okay, watch, you may be likely to have other autoimmune conditions. So along those lines, Eden, can you talk a little bit more or go into a little bit more depth on staging? Like, what are these stages of type 1 diabetes?
Yeah, and I love what Maya said too, and what she talked about also applies to adult, because I do adult related diabetes, and I saw in the chat a little bit of, I have pre-diabetes, I'm an adult, guess what? Screen. It's okay to screen adults too. We're dealing with that as well. And so when we look at it, it's kind of like chapters of your health. And it could be that you have chapter 1, and that is you have an antibody. And in that chapter, that you might stay in that chapter for a long time, right? You may be there. It may slowly progress. I've heard a few LADAs in the chat. We call those latent autoimmune diabetes of the adult, slow progressors, one antibody, and they just kind of creep along over time because it takes a while for their own, how shall I say, autoimmune kind of dysfunction to occur. And how do you know with each person? So you periodically look up, right? And so when you're in stage 1, you have 1 or 2 antibodies, but your blood sugars are normal. Now let's define normal. Stay tuned. Many of us are defining normal in the next few months because we're Richard Bergenstahl and the other Dr. Miller and I are working on that. But let's just call it non-diabetic. A1C is less than 5.7. You don't have a sugar problem. That's stage 1. That's where you and your clinician, depending on your age and your family history and your risk, you're going to take a cadence of how you're going to monitor. You're going to figure it out. How often? What are we going to do? We're not going to freak out. We're just going to glance at it every once in a while. You're all going to monitor and rescreen at different times. You're not going to say, oh, you're done. It's just that you're going to look up again. Now, let's say you then now have 2 antibodies and you start showing your colors. You start having blood sugars that are in what we call stage 2 that are called dysglycemia. That's a fancy word for you're a little bit sweet. And it's still not what we call the tipping over into the overt diabetes. This is actually, to be honest with you, a bit of a hard segment. We have it defined, but that definition is pretty broad. It's an A1C of greater than 5.7, but less than 6.5, a fasting, that's 100, but 125. I mean, just these, we make marks. But again, many of us are working in the field of stage 2 glycemia to define it better, because we want to be able to identify and do a better job of monitoring. This is where I think the amazing prevention lies. And this is where it's not quite the way of stage 2, but I think all of us on the panel would agree that we want to be utilizing continuous glucose monitoring, either intermittently or continuous as you're in the dysglycemic. We're looking so forward to maybe being in a future of a dual glucose ketone sensor that's not out yet. So just we're setting the foundation for future innovations for screening, staging, and monitoring. Why? Because guess what? If it's gonna come, it's gonna come. And yes, we have grief associated with that, but I sure would want to know as a person or a clinician to be able to empower them with that inevitable and to be able to make that road smoother and not this terrible diagnosis with all the things that come with it, and to be able to ease in and to be a master before it ever actually came.
I think that's a really interesting point because, in 2015, when that ADA guideline came out, not a guideline, but hey, look, we stage type 1 now. We look at this. You and I and Corey and the rest of us, we kind of stuck it on a shelf because it didn't mean anything. We didn't know about the reduction of DKA when we knew ahead of time yet, right? We didn't know about that. There were no treatments. I mean, when we speak to our friends and there's a lot of people in the chat talking about this. My primary care didn't know. I tried to ask what's happening. And the answer is that we are just getting into education about screening. And we need to remember what the ADA guidelines say right now, which is every first degree relative of a person with type 1. So I have a .T1D screen that spits out your parents, your brothers and sisters and your children. I do adult, right? And your children need to be screened. Then if they're negative because I do adult, if something else happens, someone ends up with type 1, someone ends up with Hashimoto's, I'll actually rescreen those same people again, just in case, because it's telling me, here it comes, here it comes. And we have to be, we have to understand that we are dealing with something that's pretty new, aren't we? I mean, it's only been 10 years ago, you guys. That's when that first article in Diabetes Care came out.
Yeah, I think there's so many good reasons to screen. I mean, we talked about the reduction of DKA, and just recognizing and being prepared, but also with treatments, some treatments already available, other treatments hopefully soon available, lots of excitement in this space. So I want to make sure we allow enough time for questions. So what I want to do right now before we get into Q&A is do a round robin and ask each of our panelists to just give us 1 to 2 pearls on this topic, kind of summary points on this discussion. Eden, I think I'm going to go with you first.
So my biggest thing is, like I say, if in doubt, check it out. You can't be harmed by screening. You can't. Yeah, sometimes it's hard to do hard things, but knowledge is power. Have a low threshold for asking your clinician. You clinicians out there, listen to your patients. They know best for themselves. Remember, we're their Sherpas. We're guiding them through life, okay? And so let's put this top of mind and let's answer that question in order to detect this in individuals who otherwise don't know.
Awesome. Thank you. Stacy, how about what do you think? Your key
Sure.
points.
I did not mention yet, I have been screened. I got screened at my son's camp a long time ago, because I thought it was worth doing. I kind of wanted to see if, when I was negative, I blamed my husband and I was like, haha, it's your fault. But then my cousin's kid was diagnosed and that was my side of the family. So curses foiled again. But I will say that, if you're here watching this, listening to this, live or taped, then you know that there is a community out there. So if you are nervous about screening, if you have been through screening and you don't know anybody, please reach out. This is an incredible community, and it can be very, as we've said, it can be scary, it can be uncertain, but there are people who want to help, people who live with type 1 in any stage who want to connect. So my advice would be get screened, get your kids screened, but find yourself the community, whether it's local, online. There's good people who really can support you.
Awesome. And Corey.
Yeah, I mean, I think what Stacey just said is so important. I'm not sure I could emphasize it enough. I think that what I would also maybe piggyback on that is to note for everybody that there are so many people that are working on in areas related to this, and so screening opens the doors for so many other potential opportunities for your health. It can be related to autoimmune conditions, but there are also a number of other things that we'll learn along the way. And so it really, in some ways, I kind of feel like it's a gateway to some more opportunities to optimize health and to be safer. One of the things that we're going to talk about, in the next couple, which I think are really important, are around treatment options. And a lot of that focuses on preserving beta cell functioning or preserving glycemic metrics. But I kind of think about screening as an opportunity to preserve your life and preserve some normality and to kind of extend that portion.
Awesome. And then, last but not least, Maya.
Team screen, bringing up the rear. I think, I can't say it enough. And again, we all have these personal stories, but I am team screen, and for many different reasons, for the increased risk factors, but for also those who do not meet the typical type 1 diabetes profile. So that means for people older than a certain age, over 50% of people with type 1 diabetes are diagnosed after 20 years old. People who are of African descent, Latin descent, they are not considered the profile. People who are overweight, they should all, like Eden said, it doesn't hurt. They should all be screened. On the other side of the coin, for those of us who are practitioners, Corey, I'm going to say that I love psychological burden. I don't know why I'm this old and have never heard it before, but I love that term. But we also need to keep in mind those that are reticent to get screened and give them the appropriate anticipatory guidance. Don't bully them. Don't make them do it, and say, look, I understand we have all of these avenues open for you to discuss and feel about it. And then I'll bring it up again. Because in 2 cases, I have talked about screening at a visit, and then I repeat the family history, and a grandparent has been diagnosed with type 1 diabetes since our last well visit. So.
Wow. Thank you so much, all of you. We really appreciate it. So we are going to open to questions. And so I think we're going to get fed some questions based on all of the questions. I can say that a couple of us could probably pull some off of here, right? So how do you screening, if someone has a high deductible plan, we will go to something like either Ask, which will screen for all 5 antibodies, and as well as celiac. Ask is a trial based out of Colorado. And the one thing I will say about that is when you go to their website, you can just do Ask Diabetes, Google that, and you'll find it. The challenge with it is it was started for kids. So don't get discouraged, because it's not. It is now a population-based study, and they do offer that for free. They will send you a slip to go to a LabCorp, or they will send you one of those cards where you do a finger stick and bleed onto the dots. So I would just add that as a yes, we can screen for free. You can do it outside your office, but just like Maia said, if we code correctly and just say family history of type 1 diabetes, family history of celiac, family history, I am not getting kickbacks. The only time I'm asking is if someone's on a high deductible plan. Okay, so let's start with some of these questions. Does anyone have anything else to say about cost? I know that Dr. Miller put in the chat, cost of DKA is $6.9 billion a year, right? So never mind the emotional, you got to stay in, you got to do this, you got to do, it's a tough one, right? The emotional side of that.
I think
okay.
that, Natalie, one thing I would add is that, I mean, I know that there were some questions and discussion about, barriers to screening, and I think you're highlighting a big one with cost. I think that people, they can worry about cost in terms of how much is this, going to cost out of pocket, or the things that I might have to do for screening. And then there's also a little bit of maybe a, personal cost to privacy. And I think that there are a number of people, particularly parents, who worry about, okay, if we have this information, what comes next? Or is anybody going to have access to this? Is my kid's future employer going to have access to this? So there's a lot of these kind of, I think, they become maybe ethical questions for people. But I think one of the jobs that we have as healthcare professionals is to ensure that this is private, that we keep the information private. We only use it for the purposes that we're going to, in terms of thinking about what's next. But the reality is that screening is going to confer in the general population, 99 times more people without it than with. And so I think that there's also sometimes a forgotten facilitator is that this, does give you kind of one less thing you have to think about or to worry about, and also can alleviate some concerns for families that have a family history.
I think that's an excellent point. There is a question. Someone actually said she had her in the chat that her teenage sons were screened. One has 2 antibodies, one has 1. You need a referral to an endocrinologist. And we can talk about endocrinology deserts across the country. So depending on where you live, you just need the closest one. A lot of us are doing virtual consults for some of this because that's what we have options for. Dr. Miller, do you want to touch on a little bit of that? But we need to get you to someone who knows what they're doing, right? Because we do want to treat you. We do want to screen. We might want to offer you a CGM. There's all kinds of things we can do for those people.
And it's about networking because, yes, endocrinologists are formally trained, but I'll be honest with you, some endocrinologists do not want to do diabetes. It's not anything against them. It's just how they construct their practice. And so there are also, as Natalie mentioned, there's a new fellowship, which I completed. I'm a unicorn. I'm a family medicine specialist, but I'm a diabetologist. And so I have practiced at a very, very, very high level. So what you do is you look for your people. There's ways to go to the Beyond Type 1 group. There are so many different resources, diaTribe, and you just start networking. Hey, I'm looking for somebody who's knowledgeable regarding this area. Yeah, sometimes you got to be proactive in your health, and I know that's a challenge. But you know what? With internet, with those, it's only just a couple clicks away, by doing, who's screening for type 1, or how can you do this, and how can you follow them? Because, the one with the two family, I have a group of identical twins, and we watched one get it, and then we were closely following the other. And you want to have somebody in your court going with you along the way, helping you navigate all of that, either the diagnosis, because guess what? Then if you do end up getting a diagnosis, you're already home. You're already there, and that ability to do that. And so, just find your people, and you are all probably only a couple people connected away. And so just keep asking questions to find that person that can help guide you, from the CDCES to the PharmD to the clinician. They're out there.
I absolutely agree. And then someone else asked about, can we see data before we actually can CGM show trends? And that's a really great question. We're using CGM early on when you have 2 antibody positives, and we can see time above 140 milligrams per deciliter for those of you in the US. And we're watching that. And at a certain percent, we say, okay, now what? This is now a person that probably needs to come back in and do more. So we are using CGM. The challenge right now is we don't have absolute guidelines, but if you hold your breath, Dr. Miller is going to get us that in the next year or so.
Natalie, I just want to share, there's a really interesting comment in the chat from Sarah, who said that she actually attended a presentation that you and I did together about screening and went ahead and got herself screened and was actually diagnosed with stage 2 type 1 diabetes, based on seeing our talk. So I think raising this awareness is really important. There's likely a lot of people out there living with what they think is type 2 diabetes or pre-diabetes and may actually have type 1 diabetes. So Sarah, thank you so much for being willing to share your story.
And we actually had one of our colleagues, a PhD student, we were all at the ADA a few weeks ago in June, and we made all our PhD students screen, and one of them screened positive through this is what happens, you guys. 90% of people don't have a first degree relative, right? So, ultimately in places like Italy, they've just started general population screening. And we hope one day that happens, just like lead, just like, right, other things that we screen for, because we know we're going to miss some, and we don't want to. We don't want to miss anyone ever again. Okay. Anyone else see a question they would like to answer?
I was going to add to one of the barriers to screening is, we talked about it, alluded to, didn't say it, is that insurance doesn't always cover it. But also the other one that Corey alluded to also is that people are often very concerned about what may happen later on in life with insurance. And if you have a diagnosis of type 1 diabetes, now we all know the cost of DK and all these other things, it will actually reduce the cost that you know in advance, but not everyone thinks rationally when things come up.
Absolutely.
Yeah, and I think the important thing about it is if you have 2 or more auto-antibodies, your chance of developing stage 3 type 1 diabetes is basically nearly 100%. So yeah, it's kind of a bummer insurance-wise, I guess, but at least you're prepared. And if you only have 1 auto-antibody, then you don't have a formal diagnosis, and hopefully your insurance costs won't go up.
So another person, Jeff, said he has a 38-year-old daughter who has type 1 since age 3, and her nephew and niece recently both had Coxsackie virus. So is that a trigger? So it doesn't move, and asked if we move up the priority to get tested. So anyone can be tested. Anyone can be screened for type 1 diabetes. We want to make sure that people understand that. I don't know. You can go to the ASK study and be screened for type 1 diabetes. You can call. You don't need a provider to do it for you. You can do this. You can go online, and you fill out their forms, which I've done for patients in my office before, and it is not difficult to do. And you become part of their study, right? And so they're following people who want to screen. So that is an absolute, you can do that. And I highly encourage it.
And I think the other thing is, in terms of getting screened, I mean, it is a simple blood test. There is also the finger, you can do the finger poke. It does require a little bit more than a finger stick, though, so be warned on that. But there are multiple options, and then certainly the Ask program and TrialNet. But I think if you also come equipped to your healthcare provider and you can show them, these are the 4 auto-antibodies. If you don't know how to order it, this is what you order. They can hopefully find it in their computer. Some systems will have these auto-antibody panels, but unfortunately not every health system is equipped with that knowledge and having that.
And just to add to that, Diana, these antibodies, they're not experimental. They're not things that aren't in the mainstream. They're not these outliers. These are pretty routine screening that are done over and over and over again in all persons, in all ages, in all scenarios. Because me as an adult diabetologist, I can't tell you how many atypical meaning they presented one way, and 15 years later, I'm telling them that they have type 1. And just all the signs where a clinician was too quick to jump to that. And so that's why we're talking about having a low threshold for testing. And yes, there are barriers that come, but these are overcomable barriers. They're not hard and fast barriers. They're just a little bit another steps, finding a teamwork in a clinician, getting the right testing, looking at it, finding the resources for covering it. And we screen for other things like, breast cancer and that. Why not incorporate this? And I would like to see us as a country maybe eventually adding this to our neonatal screen, and maybe even a more, how shall I say, less of a burden way of doing it. I think we'll get there someday.
Yeah, and I mean, one of the things we're routinely doing in adults, unfortunately, I'm an adult endocrinology, so people usually already have a diagnosis of diabetes, but it is so common someone thinks they have type 2 and they actually, they have type 1. And so we're screening for these auto-antibodies and they're already in stage 3, but at least now they know the type of diabetes that they have and, how to be treated. So, but the goal would be that we catch people earlier. It's not until they've been living with this for years, trying to manage it with like metformin and oral medication, when they ultimately will need insulin.
Yeah, I think that's a really...
Go ahead, Corey.
Oh, sorry. I was just going to say, I think it's just such an important point. And I know in the chat, and then there's been some conversation about type 2 as well. But I mean, there's so many misdiagnoses. And I think people sit in this zone of being confused about what's going on, and also get frustrated with treatments that don't work. And when you don't have the right diagnosis, you don't often get the right treatment. And so I think that this, screening can be really at any point in the, before any signs of it, all the way till you're thinking about a misdiagnosis. And I think that that's how we've used it clinically, but I think that there are some applications, kind of more broadly as well.
Yeah. Yep. Basically rule out type 1 diabetes whenever you're thinking. Mm-hmm. Makes sense.
For sure.
Right. It never hurts to check those antibodies.
Absolutely.
There's any doubt, check it out.
Oh, I love it.
Yep. That is absolutely, I think that is our message for our program here. So, and Stacy, do you want real quick to tell us about Mom's Night Out?
Yeah, sure. I would also say too, I always think during
talked about it there, because you were in Cleveland and we did, right? We talked about screening with the moms. So
yeah, I would also say every time this comes up, I just think about my son at 23 months old, and boy, if we just had a little bit more time.
Yep.
Right? Because boy, it was just, it's toddler and type 1 is, I mean, it's all bananas, whatever age, but when you can't even say diabetes, the diagnosis is a little different. But yeah, Mom's Night Out is an event for moms of kids with diabetes and women with type 1. We will be in Minneapolis in September, and we will be in Phoenix this fall, and 4 more events next year. So thanks for giving me a chance to talk about that. But it's an amazing place to find education, technology, community, and conversations like this.
Absolutely. I can't recommend it enough. They came to Cleveland we came and they do a wonderful job. And it really does, like Dr. Miller said, find your community, wherever that is, however that looks, whether your child, you guys are going to family diabetes camp, whether you're a parent, whether you're a person with type 1, there are more and more resources out there for people with type 1 diabetes. And I think when you find your community, you can work through some of these questions.
100%.
Can't you? You can say, I really don't want to screen. I feel so guilty on this, on that. And people go, I'll hold your hand through this, right? I'll help you do it this way. I screened and it was negative. Most people are going to screen negative, right? So we need to remember those things and kind of hold each other's hands through it. So Stacy offers an amazing program that they've developed, all by themselves. And it's yeah, if it comes near you, I highly recommend it. So
much.
Here we are, closing remarks. Our next panel, we'll discuss So You Screen and You're Positive. We really talked about this initiative to let's get people screened. And now what? Now what are we going to do? We will talk about monitoring guidelines and what's happening in the real world relating to monitoring, including CGM use. Because when we look at the guidelines, we as clinicians, we're already doing it more aggressively than is already recommended, because this is what happens in regular care, right? People in stage 1 or 2 in my practice have CGMs. We're using them. We're looking at them. We're guiding them. We're having them see dietitians. So there's all kinds of things we can talk about that. And the options that are available to you. We're going to talk about the psychological risks and benefits of deciding to screen. So thank you for everyone who joined us today. And we hope to see you on September 11th for part 2.
Awesome.